Yeah, so question 10 or picture station 10. Okay, picture station 10. You've been shown these two babies, okay? You've been shown these two babies, baby A and baby B, how they are actually coming through the pelvic, the pelvis, okay, the maternal pelvis. And you are asked, identify A, identify B. What are the presenting diameters and their length? Or what are the presenting diameters and the lengths associated with A and B? How will you distinguish A from B on vaginal examination at 6 cm cervical dilatation? What are the fetal etiological factors of A? And how will you manage a patient in labor with A? Is that okay?
Yes, sir.
Good. So please look at it very well. What is A and what is B? What do you think they are asking you to identify? What does this picture show?
Face presentation.
So this picture is actually what? Or these two groups of pictures are actually showing the types of presentations you can have, isn't it? What is presentation? What is a baby's presentation? Please, anybody with any idea? Yes?
The part of the fetus overlying the maternal pelvis.
Okay, so this is how you define present. I mean, that is not so far from right. Okay. So the following obstetric terms. Presentation. So we are going to talk about presentation, fetal presentation in relation to this discussion. So presentation can be defined as 1, on abdominal examination, on abdominal exam. Presentation is the part of the baby that occupies the maternal pelvis, isn't it? Please, do you understand?
Yes, sir.
Yes, doc.
Ministerial committee, do you understand?
Yes, doc.
So the mother is like this, okay? And then you are doing an abdominal examination. The baby's legs are here, see they are here. And then this is the baby's head. When you are doing an examination, the part of the baby's body you feel occupying the what? The maternal pelvis. It's actually the baby's presentation, isn't it?
Yes, sir.
Then in terms of vaginal examination, so it can actually be defined based on the examination you are doing. So on vaginal exam, presentation is defined as what? The part of the baby, is a part of the baby that overlies the internal cervical os, isn't it? Does it make sense?
Yes, sir.
Yes, doc.
Silent majority, does it make sense?
Yes, doc.
Yo. So when you're defining, please, it's based on the abdominal exam. So on an abdominal exam, you have what the part of the baby's body that occupies the maternal cervix when you are doing the Leopold's maneuvers. Then if you are doing a vaginal exam, then the part of the baby that you can palpate, or that is what overlying the internal cervical os. Okay, please hold on.
Yes.
Okay, so based on that, if you have the baby's head actually felt in the maternal pelvis on abdominal exam, or when you are doing the vaginal exam, you put your gloved hand through the vagina and then you are palpating, you go through the cervical os, you touch the baby's head. What you say is that what the baby has a cephalic or a cephalic presentation. Is that okay?
Yes, doctor.
But if you can touch the baby's buttocks or the baby's legs, okay, but the baby's buttocks, what presentation would that be?
Yes. Breach.
Breach.
A breech presentation. And how about if the baby's shoulder is the one leading, or the baby's shoulder is the one that is palpated in the maternal pelvis, or on vaginal exam, is the one that is palpated through palpated when you go through the internal cervical os. What type of presentation is that? Shoulder, isn't it?
Sure.
This is everything making sense?
Yes, doctor.
Good. Now, even for the cephalic, okay, for the cephalic, you have different words. Depending on how the baby's head is flexed, okay, you can have a vertex presentation, isn't it? I'll show you pictures soon. You can have a vertex presentation. And you have a vertex presentation when the baby's neck is what? Fully flexed. A fully flexed neck. Are we good? Yeah. So it is a cephalic or a cephalic presentation, yes. But when the baby's neck is fully flexed, then it is coming out with, or he or she is coming out with a vertex. If the baby is partially flexed, okay, then he will come with a brow. That is what is called a brow presentation. Okay?
Yes, doctor.
And if the baby's head is actually hyperextended, then he will come with a face. Sometimes you can have chin presentation and all, but we'll end at what? Face presentation. Is that okay?
Yes, doctor.
And even for the breech, you know that we have what? Putling breech, complete breech, frank breech, and all that. We'll see another picture station that talks about that. So let's not worry our heads. So for now, let's focus on the cephalic presentation, the various ones. Okay. So I'm going to show you pictures. Then you would appreciate what I'm talking about. So just to highlight on the types I mentioned, forget about some of these things they are saying. So this is what the part of the fetus's body that was palpated on abdominal examination. When we went through the cervical canal, the part we palpated overlying the what internal cervical os. So this breech, this is what cephalic. All right. So good. So do you see this? And don't be surprised when they project this thing for you. You see what I was talking about? So you see this baby's neck is fully flexed. Do you see that?
Yes, doc.
So because the head is fully flexed, you see that he's coming with his what? His vertex or the crown. Once he is partially flexed, he comes with his brow. And if it's what? Hyperextended, he comes with his face. Do you see that? So those will give us the vertex presentation, brow presentation, and face presentation. So really the difference is that, or what determines how you would classify it depends on what? The degree of flexion of the neck. Fully flexed, I repeat, vertex presentation. Partially flexed, brow presentation. And then if it is extended, you have a face presentation, okay? All right.
Yes.
Let's go back to our question. So if you look at these guys, what do you think? This is a cephalic presentation, but it is not enough to write cephalic presentation. No, there are actually types. Okay, so what do you think A is based on what you've discussed so far? Stephanie, what do you think A is?
I think it's a brow presentation.
Are you sure? Watch it very well.
Yeah, because I don't think it's hyperflex.
Are you sure? Do you not appreciate that the baby has hyper extended and look at the neck? How straight it is. Look at where the occiput is. You know that none of them is vertex, isn't it?
Yeah, none of them.
Huh. So if none of them is vertex, it means that one of them is brow, one of them is face. So the question is, which of them
So
is
that is the hyperflex and face presentation.
exactly? So what you write is what? You write A and you put dash. That is how you are supposed to answer this question. A, don't do A is no, A dash. Then you put face presentation. Do you all agree?
Yes, doc.
Yes.
And B, as you see, B is not fully flexed, but it's not extended. So that has to be the brow presentation, isn't it? B, brow presentation.
Yes.
Yes.
B is the brow presentation. Okay. Then the next question is asking, what are the presenting diameters and their length associated with what? A and then B. So you see, when the baby is coming out, I mean the head, right? There are actually some diameters, I mean the length that they come out with. It's either what? A transverse diameter or an AP diameter. Okay? Let me show you pictures. Let me show you pictures of what I'm saying, what I mean. Regina, are you okay?
Yes, doc.
Presenting diameters of the fetal skull. So I just want one. Okay, let me see. So the diameters are actually 2 for every presentation. It's either they have what? An AP, okay? So antero-posterior diameter and then a transverse diameter, okay? AP, transverse, AP, transverse. Is that okay?
Yes, doc.
That is the first principle you have to keep in your head. That when we talk of presenting diameters, we have 2. You have to think of 2. Every presentation has it, because you know that the maternal pelvis also has what? A transverse diameter, okay? And then an AP diameter, isn't it?
Yes, Doc.
So it has what? A transverse diameter and an AP diameter. So the fetal skull also has what? An AP diameter and a transverse diameter. Always think of AP diameter and then what? Transverse diameter. Now listen. Let's go back to the next and go and look for AP diameters of the fetal skull. I'm hoping that this time they will give us a very clear thing. Okay. So look at this. I mean, relate that this is actually the fetal skull. I mean, looking from at it from the top. Do you see that?
Yes.
Yes.
When we say transverse diameter, this is what we mean. So one of the transverse diameters can be from the parietal eminences, okay? Who say obiati, okay, on the side now, parietal eminence, be all. So you draw a line there, and that would be the biparietal diameter. So it means that biparietal diameter is a transverse diameter, isn't it? It can't be an AP because it's not measured like this or even like this. It's from here to here, so transverse. Another transverse diameter is what? Look at the temporal bone, okay? And then draw. You have what? Bitemporal diameter. BTD, BPD. Is that okay?
Yes, Doc.
Good.
Right.
Now let me see if I can get some of the AP diameters. Good. So you see, you've seen the transverse diameter. Now let's look at the AP diameters. So who can what is this structure? What is the name of the diamond shape structure I've highlighted?
Anterior fontanelle.
Okay, anterior fontanelle. That is true. Now, that is also called the bregma. Okay, please take note of that. Okay.
Yes, Doc.
Yes, Doc.
When you are discussing the fetal diameters, the anterior diameter is actually the bregma. So listen, the AP view. If I draw, I think this is even clearer. Let me show this. If the baby is coming with this is an AP diameter. So you've seen the transverse diameter. Now listen, if I tell you that, look, the presenting diameter is from the anterior fontanelle to the occiput, and I join that to the line, I say this is the occiput. Okay, so you have gone underneath the occiput, isn't it?
Yeah.
Yes.
Yes.
So that will be called what? A sub-occipital bregmatic diameter. Sub-occipital bregmatic diameter. Okay. Are we good?
Mm.
So that is just by the way. So now let's go back to our question. Please, I hope I have not confused anybody though. Have I?
No.
Okay. So in this question, like I've said, anytime you are asked to compare in the exam, please draw a table so that you can help them to mark you. If you are doing anything you like and you confuse them, although you are right, because they are confused, you'll be in trouble because you can't remember that MDC, you can't call for an appeal. Once you call for an appeal, you know what can happen. What you write is presentation. And what are the presentations you have identified? A was what? Face. And then B was what? Brow. So I said that the diameters, you always think of two. AP diameter and then transverse diameter, isn't it?
Yes. Yes.
Now, for the face, because he is hyperextended, let's go back. Because he is hyperextended, let's go to the Cephalic presentation types. Watch this again. Please, if you join, close, stop your video, okay? I beg you. So look at the face presentation. You see that, yes, of course, the biparietal diameter is actually the transverse diameter. But what is the AP diameter? Look at it. If you look at him very well, you see that what he will actually present with, okay, is his chin underneath, and then the what? The anterior fontanelle. Do you see that?
Yes, Doc.
Please, you all appreciate that.
Yes, Doc.
Yes, and then look at this guy, his brow. What do you think? The brow presentation is actually from here, okay, to the vertex, not even the bregma. So you bypass the bregma a bit to the vertex, like this. His AP diameter. And when you look at the face, the vertex presentation, you see that it is actually from the bregma to the what? Occiput. So the AP diameter of this one, of vertex presentation, is actually sub-occipitobregmatic. This one is what? What is the Latin for chin? Or what is the French word for chin? Le what? Again.
Is it mental?
Menton. Menton. Why? Le menton. And actually, the Latin word for chin is actually mentum. Okay, mentum. So it will be what? Mento vertical. Do you see that? That's the vertex. That's the crown. Okay, the highest point of the head. Mento vertical. Mento vertical. And this one will be what? Submento bregmatic. Is that okay?
Doc, but the face, the line is then assuming a transverse position.
No. You see, that is why I first told you what transverse was. Transverse is this. Is this. So you see, if you watch the mechanism of labor, now you are sending me to a place I don't want to go. But please, how should I approach this?
Okay, so you are using the diamond shape as a landmark, right? So
yes,
you are using the as a landmark.
Yes.
For the anterior posterior diameter.
Yes. Yes.
Frontal, or anterior frontal. Okay.
So you see, because he will not bring this whole thing into the pelvis. So no, if you watch it very well, because his head is hyperextended, it's not this whole thing that will enter the pelvis. If you look at it very well, okay.
Okay.
Yes, hyperextended. So is this one that he's presenting with, but he has a transverse diameter. It can either be what, bitemporal or biparietal. That's why I established those two principles for you so that you not get confused.
Okay.
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 So the long and short of it is that the long and short of this conversation is that, again, let me draw there. So please kindly note that for the transverse diameter, okay, for exam's sake, don't worry yourself. You can either have two of them, okay? Either a BPD or BTD. Okay, and I'm saying that presentation here, AP diameter here, and then transverse diameter there. So then you write face presentation. For face presentation, okay, for face presentation, when the head is fully extended, like the picture we saw, then it will be a submentobregmatic. Submentobregmatic. When the head is fully extended, face submentobregmatic. And I want you to note that anything that involves the bregma, okay, is 9.5. That is the mnemonic, or that is the way I used to remember it, okay? So suboccipitobregmatic will also be what? 9.5, isn't it?
Yes, Doc.
So anything that involves the bregma is 9.5. And you see its significance soon. The transverse diameter that the face presentation presents with, please, it is the biparietal diameter. It is the biparietal diameter. And the BPD is also this. Please hold on. Are we good? Are we good, please?
Yes, Doc.
Yeah, but sometimes you can have a face presentation where, yes, there is full extension. I mean, there is extension. It's not broad, but it is not so full. It is not so full. Please, you understand me? You let me leave it up to this. Don't let me complicate it. So face presentation, fully extended. They will present AP with what? Submentobregmatic, and transverse with what? Biparietal diameter. For brow, they will present with what? Mentovertical. Like I indicated, okay? Mentovertical diameter. And do you know the length here? Who knows the length of the mentovertical diameter? Who knows?
11 point.
No, it's 14.
Okay.
It's 14. And we would see the clinical significance here. Of course, it is still BPD here. Okay, that's nice, 9.5. Now, for the maternal cervix, pelvis, for the maternal pelvis, the largest diameter in the pelvis is 13 cm. The largest diameter, the largest ever diameter you can ever get in the maternal pelvis is 13 cm for a gynecoid pelvis. So what is the implication for a baby who presents with a brow presentation? Who can answer that? Think about it.
Would it be a cephalic pelvic disproportion?
Yes. The woman cannot deliver vaginally. She can't. Please, do you understand? Because you see, you know that pregnancy is made up of what? They say it's made up of the passageway, the passenger, and then somebody. I've forgotten the last person. Who knows? What? In the power. Very good. Very good. In the power. The 3 P's of labor. Can I clean this board? Can I clean this board? Have you made a note here? Can I clean the board?
Yes, please.
So please note that if they showed you a vertex presentation, okay, the AP diameter would actually have been sub-occipital bregmatic. That is also 9.5, and a BPD, where is 9.5. So do you see that a woman can deliver a face presentation and a vertex, but not a brow presentation? Brow presentation cannot be delivered vaginally. What did I say?
Brow presentation cannot be delivered vaginally.
Yo. So for labor, the power comes from what? The uterus. For labor to be successful, the power is generated by the uterus. Then the passenger, oops, please hold on. My battery is going flat. The passenger, who is the what? Baby, right? And then the passageway, that is the mother's pelvis, isn't it? The maternal pelvic canal, right? So for you to have a successful delivery, the power has to be strong, and then the passenger has to be able to what? Pass through the passageway, isn't it? That's why you can have a CPD. CPD, the power is strong, yes. There's no problem with the baby, probably, but the passageway is too small. Or the passageway is adequate, but the baby has a congenital anomaly. The passenger actually has a congenital anomaly or has an abnormal presentation, a malpresentation, so cannot pass through the passageway. Remember, for labor to go on successfully, the power has to be adequate. Passenger, yes. Passageway, adequate. Okay? So if you are saying that the largest diameter the passageway can offer you is 13 cm, and you are coming with a presentation in which one of your presenting diameters is what? 14 cm. Do you think you will ever pass through the passageway?
No.
And so MCQ takers, which of the following presentations cannot be delivered vaginally? Answer is what?
Brow presentation.
Yo, boss. So when we're in school, there was this lecturer called Dr. Wilson. No, it's not Dr. Wilson. He's a sir. Those senior, those 9. He was called Sir Ninth Wilson. I've forgotten his. He had one English name. This guy, when you go and meet him, forget. He was very malignant. He was very, very malignant. So what we used to call him was what? Brow presentation. They say that our students will say, Charlie, who was at the station? Charlie, it was brow. It was brow presentation. Why do we call him brow presentation? Because we know that if you are a baby and then you present a brow presentation, you would have what? Failure to progress, isn't it?
Yes, sir.
So instead, Charlie, who is in there? Charlie, it's brow. It's brow. When you hear brow, it means that, oh, Sir Knight Wilson is there. And then it is very difficult to pass through his hands. So sometimes before exam, final MB in OSCE and GYN, so that we'll be praying, God, please, I beg you. Like, God, I beg. Not this man. Praying. Because he was a very difficult man. And when you go to University of Ghana Medical School and you hear brow presentation, if he's still alive, he's the one we are referring to. Once you meet him, if you're a baby, he will never let you deliver. You have failure to progress. Telling you that brow presentation, you can't deliver vaginally. Okay?
Okay.
Yeah.
Good. So you see that even question 5 actually gives us how would you manage a woman in labor with B? Do you see that? Do you see that? Do you see that they actually tested that knowledge?
Yes.
You can say, if you can say, and I'll monitor for labor. Hey, cool. All right. So let's go step by step. Question 3. Question 3 is asking how will you distinguish between A and B on vaginal examination at 6 cm cervical dilatation? So the answer is very simple, right? You palpate the fetal parts, which will indicate that you are palpating the face, or you palpate the fetal part, which is indicating that you have palpated the brow, isn't it?
Yes.
Right?
Yes, sir.
So the thing is, how will you describe it? That is the question. Because it is very simple. You actually palpate the face here, you palpate the brow here. So how will you write that? Or how were they expecting us to write our answers? So actually, when we're in school, whenever this question came, again, be neat, okay? Go with the ruler. I'm telling you that write fast and write legibly, nicely, okay? And help the examiner mark for you. Don't do chicken scratching. No. Face presentation. How will the vaginal exam be? What will you palpate? So at 6 cm cervical dilatation, you've actually you have actually dilated a bit for us to palpate you, isn't it? So
Yes.
what you say is that the face is palpated. So for A, that's A, okay, for picture A, the face is palpated. And how do we know it is the face? The face is palpated, evidenced by, we need to know. You see that the child's head is hyperextended, isn't it?
Yes, sir.
Yes.
So do you think you'll be able to palpate? Look at it. Do you think you'll be able to palpate the anterior fontanelle? Do you think so? Look at this. So the cervix is just dilated like this. Do you see that? Do you think you'll be able to palpate the anterior fontanelle?
No.
Do you see that? But you will be able to palpate the cheeks of the baby, right?
Yes.
You'll be able to palpate the nose of the baby, and then the upper jaw of the baby, isn't it?
Yes, sir.
But do you think you'll be able to palpate the forehead?
No.
No. The way this one is hyperextended, the highest can go is the eyebrow, or not even the eyebrows are. The highest can go is probably maybe the eyes. But look at the vertex. You see that you can palpate the anterior fontanelle.
Yes.
Yes. So you see, because this guy is hyperextended, there's some things you can palpate, and that is what would guide you. Okay. So that's all we are saying. So I'm going to repeat again. So for face presentation, you say the face is palpated. The face is palpated. They have to give evidence. Face is palpated. Evidenced by, evidenced by, then you start. You can actually palpate the mouth. So evidenced by palpation of the mouth. With hard alveolar. When we say alveolar margins, what do you mean? It means the gum side, okay? Is that okay?
Oh, yes.
With hard alveolar margins, that's the upper jaw. What else can you palpate? You can palpate the malar eminences. What is the malar area? When we say malar rash, you see where the SLE patients have their rash.
Yes.
Yeah, so you can palpate that 1, 2. malar eminences. You can palpate the nose. Okay. And sometimes the supraorbital ridges. Sometimes, just a few times, supraorbital ridges. Or you can palpate the eyes. Then for brow presentation, what would you say? So the brow, or that one, we simply say that you can actually palpate the supraorbital ridges, because you can palpate the supraorbital ridges and the anterior fontanelle. Do you see that? So once you can palpate the supraorbital ridges with the anterior fontanelle, please, it is not a face. It is brow. And what else can you palpate? You can palpate the forehead, isn't it?
Yes, sir.
That is the sinciput. If the back of your head is the occiput, you don't say if my etikopo, sinciput is the forehead. So you can palpate the sinciput. And what? Sometimes you can palpate, I think that is where it ends. So you can palpate the anterior fontanelle and then maybe the vertex, but the occiput may not be palpated. So this is the sequence. Supraorbital, when near chino, we are not about the umuma. Then you count the what? Anterior fontanelle and then the vertex, but you may not be able to palpate the occiput. You may not be able to palpate the occiput. Is that okay?
Yes, doctor.
Doc, please, I have a question.
Go ahead, though.
Please, when do they usually have bitemporal presentation?
Bitemporal presentation. When you say bitemporal presentation, what do you mean?
Sorry, bitemporal diameter on
Diameter.
presentation.
When they have asynclitism. When you're brofredru, I mean, it is also a concept in ONG. I mean, labor. We'll talk about that later. Okay. You have
Okay,
synclitism. So asynclitism, it's okay. It's okay. I've answered the question. It's okay. But I should mention that some books also feel that sometimes when they come with a face presentation, they may have the brow, I mean, the BTD, the bitemporal diameter. Okay, some books think that it can be a bitemporal diameter as the, engaging transverse diameter, but usually it's a BPD. Okay?
Okay, Doc.
Please, can I move on?
Yes, doctor.
Sandra, this is your name, eh? Is it? I don't know. Is it like Sundiata or what? Anyways, that is fine. Good. So let's go back to our question. So the next question says, what are the fetal etiological factors of A? Why would a baby present with a face? That is from him. Yes. Okay, there are very few, okay? There are very few. So it could be that the baby has what? A congenital anomaly, like anencephaly or anencephaly. So congenital anomalies, that's what prevent the head, prevent us from flexing the head, okay? So congenital anomalies, sometimes they have a goiter. They want to what? Flex, and then the goiter is preventing them, okay? So congenital anomalies like anencephaly, like anencephaly, okay, fetal goiter. This word, one of my colleagues, while we were in secondary school, said goitre. Can you imagine? Anyways, that was just by the way. Then, if the baby inherently has what? An increased tone. If the baby has an increased tone in the extensor muscles of the neck, extensors of the neck. When the baby has a lot of twisted cords around the neck and has formed like a snake, a big snake around the neck, do you think you'll be able to flex fully? Do you think? So twisted several loops of cords around the neck. Are we good?
Yes, please.
Good. So now let's come to our last question. It says, how will you manage a woman in labor with B? Don't go and say you monitor labor, because this woman is likely to have failure to progress. Failure to progress. Okay, so it depends on the viability of the fetus. If the baby is alive, the baby is alive, prepare for what? For an emergency cesarean delivery. If the baby is alive, then prepare for an emergency cesarean delivery. Is that okay?
Yes, sir.
Yes. What about if the baby is dead? You think it will be wise enough to go and section the woman, and you cut her and she doesn't get a baby?
No, doc.
If the baby is dead and then the cervix is fully dilated, okay? Cervix is fully dilated cervix. You can actually perform a craniotomy where you decompress the baby's head. Okay? That is what? A destructive delivery, okay? Okay?
Yes,
So you
sir.
destroy the baby's head so that you can actually shrink it into a very, then you actually conduct the delivery. Once you've shrunk the baby's head with craniotomy, the presenting diameter would actually reduce. But if, let's say, the cervix is not fully dilated, just go and deliver the baby via CS. Have I communicated, please?
Yes, doc.
Okay. Any questions?
No, doc.
Thank you.